Okay, testing. Okay, no problem. Good afternoon, colleagues and students. Today we have two talkers, and before the two talkers, we are honored to have Professor William Wong to give some general remarks about the field. Professor Wong, please.
These lectures, you probably know, are organized by the Research Center of Language, Cognition, and Neuroscience, RCLCN. And the director is Professor Peng Gang. He's asked me to say a few words to provide some background for the two lectures this afternoon. With remarkable prescience, it was Hippocrates in ancient Greece who first speculated on the numerous fundamental functions that our brains serve in our lives. Okay? Even now, we misidentify the organ. We say, somebody broke my heart. We say, 小心一点. It's not the shin, it's not the heart, it's the brain. And Hippocrates knew this some 2,000 years ago, before the very first studies of neuroanatomy were done by Vesalius. But connecting impaired language and cognition to the brain was not achieved until much later, mid-19th century, with Broca, Wernicke, and so on. Neuroscience itself did not begin until the 20th century, when Cajal worked out his neuron doctrine and went on to win a Nobel Prize in 1906. Only from then did we understand what the basic building blocks of the brain are. Compared with broken bones or blocked arteries, brain disorders are many orders of magnitude more subtle, much more difficult to understand, let alone to prevent or to cure. It's primarily over the past century that various forms of disorders of movement, coordination, memory loss, orientation to reality were successively traced to their neurodegenerative causes. Some of these diseases have been named after the physicians who first studied them, such as Parkinson's, Huntington's, and especially Alzheimer's, which is by far the largest share of patients with severe dementia. These challenges are difficult to meet, in part because neuroscience itself is very young, and our knowledge here is still very limited. We still don't know, for instance, how many types of neurons there are in our brains. They're difficult also because these diseases mostly come to the surface when people get old. And rapid population aging is itself a recent phenomenon. A disease like Alzheimer's could be with you for 10, 20 years before you have a clinical diagnosis. And population aging is something that largely happened within the last century and a half. While advances in science and technology have brought ever longer lifespan to our species, the sunset years for many are plagued by failing health and debilitation, bringing tragedy to the family and immense economic burdens to the society. Fortunately, various governments are taking action to meet these challenges by providing substantial funding including the United States. Bush, for instance, declared the decade of the brain, Europe, and China. In 2016, as an example, the National People's Congress in China launched a very far-ranging 15-year brain project. Many measures are being taken to overhaul insurance policies, to adjust retirement ages, to educate the public on the changing demography across the world, and how to take better care of their elders. Above all, science and technology are also zooming in to better understand the nature of neurodegeneration so that we can better cope with it. The two lectures about to be presented this afternoon reflect well the wide spectrum of efforts that researchers are now making to meet these challenges, from the molecular to the cognitive. Dr. Anna Wong is an immunologist and neurologist. She comes from the Hong Kong University of Science and Technology, where Professor Nancy Yip, new president of Hong Kong UST, her laboratory has been doing leading edge work on Alzheimer's disease. An exciting discovery they recently reported has to do with stimulating interleukin-33 and decreased deposition of the pathogen amyloid in the brain. I didn't understand what these terms meant and had to do a lot of homework, but necessary homework. Dr. Fong, Manson Fong, is a member of the Research Center for Language Cognition and Neuroscience, RCLCN, and of the Research Institute of Smart Aging, RISI, both of the Hong Kong Polytechnic University. With background in engineering and linguistics, he has been using methods of EEG and MRI to study cognitive aging, especially the processes of facilitation and inhibition in various language tasks. As we will see in a minute from their presentations, we're only beginning to meet the challenges of neurodegeneration. A great deal of deep thinking and innovative experimentation are needed to integrate the findings from the many disciplines and to close the many gaps in this wide spectrum of efforts. It will be a long journey to lead from understanding to prevention to cure. But at the same time, we should take comfort in their presentations, in that the first collaborative steps across disciplines toward meeting the urgent challenges of neurodegeneration are being actively taken. Okay. Now I return the floor to Director Peng Gang, who will introduce these speakers. 这个你要用吗?
Okay, thank President very much for his very informative introduction. Okay, now I'm going to introduce the two speakers today. Dr. Anna Wong is a registered neurologist and previously worked in the Department of Medicine at Queen Elizabeth Hospital in Hong Kong. She has been working on autoimmune neuropathies during her clinical years. And after obtaining the fellowship in neurology, he went on to her PhD study at the National University of Singapore. And now she is working at Professor Nancy Yip's laboratory at the Hong Kong UST. And his talk title today is Regulation of the Microglial Functions by IL interleukin 33/ST2 signaling signaling, developing therapeutic targets for Alzheimer's diseases. And our second speaker is our podium speaker, Dr. Manson Fong is a research assistant professor in the Department of Chinese and Bilingual Studies, and also a member of RCLCN. After completing his BSc and MPhil in physics, he got his PhD in WE from CUHK, where he studied the link between the perceptual space and event-related potentials. He did his postdoctoral work with Professor William Wang, focused on using an individual differences and multimodal approach to clarify the associations between cognitive and semantic functions. His current research interests include the neural reorganization in aging, neuroplasticity induced by foreign language learning, and the brain age markers for dementia. And his talk title today is How Do We Understand the Age-Related Increase in Semantic Priming? Now let's welcome our first speaker, Dr. Anna Wang, please.
Okay. Good afternoon, and thank you very much for inviting me. And also the kind introduction. So it is my honor today to share with you something about Alzheimer's disease. So I'm Anna. I'm from Professor Nancy Yip's laboratory. I'm sure you know who she is, and at Hong Kong UST. So today I want to talk about actually something with Alzheimer's, and then also some exciting findings our lab has produced recently, which is on the regulation of the microglial functions through the IL-3 ST2 signaling, which we believe it will be a future direction for new therapies for the treatment of AD. So today I will cover a few topics. First of all, I will talk about Alzheimer's disease, epidemiology, the risk factors, the clinical presentation, as well as the current treatment modalities. Then I will show you some of the local data we've generated with the hospital authority. And then we'll go on a bit to talk about what has happening in AD, pathophysiological changes, and the role of microglia, which is the target of our research. And then I will show you some of the recent findings we've published on the IL-33 ST2 ligand signaling and how it regulates the microglia function and then the amyloid pathology. And then another major important finding is we identify a plasma soluble ST2 as a new biomarker and a possible therapeutic target of AD. So let's start with AD, so Alzheimer's disease. So Alzheimer's disease is the commonest cause of dementia in the elderly, and is one of the most common neurodegenerative disease other than Parkinson's and Huntington's. So the very important point of AD is that it's a triad of the symptoms of progressive memory loss, cognitive impairment, as well as neuropsychiatric symptoms. So we generally classify AD into an early onset and a late onset with a cutoff of 65 years old. So which means that if the patient's onset of symptoms is after 65 years old, is the late onset AD. Today, my focus will be mainly on the late onset AD because it's mainly comprised of most of the AD cases we see. So for the patients with AD, the problem is that the decline in the cognition, what we call the higher brain functions, and the impairment of the daily activities will continue. So meaning that from a mild symptoms to moderate symptoms to severe stages of disease. And now we call AD more as a continuum. So which can last from normal, that you don't have symptoms, mild symptoms, and the later dementia, it can last up to 25 years. So it basically may be 1/3 of or 1/4 of your life. So how common is AD? It's actually very common. So the estimated global prevalence by 2040, that means not long later, will be 82.1 million worldwide. So based on a landmark study of the Delphi consensus study in 2005, we are in the China and the developing Western Pacific. So by 2040, we'll have 26.1 million people living with AD. In China, from a study in 2018, it is estimated that more than 7 million of people were living with AD. And the cost per person, all kind of costs, will be around 20K USD per year and up to 167 billion US dollar to the society. In the US, we also see a lot of patients with AD, 6.5 million from the latest study in 2022 last year, and the cost a bit higher, 40K per person per year. So you can imagine if, like here, the prevalence is high and the socioeconomic burden to the society will be increasing because we have global population aging. So what are the causes of the Alzheimer's disease? So first, of course, is the age. So this is a diagram from systemic reviews of many different studies summarizing the possible risk and protective factors for AD. So you can see the kids, so you grow up until you're in the elderly. So age is the strongest risk factor. So if you grow older, your chance of getting AD is higher. Female, we don't know why, is also have a higher risk than male to develop AD. So, and then most importantly, we have lifestyle factors and medical conditions. So some of the lifestyle factors, for example, exercise, healthy diet pattern, vitamin C is beneficial. While a lot of medical conditions and lifestyle, for example, smoking, hypertension, obesity, and some of the cardiovascular disease are risk factors. So which means that actually we can modulate the risk of the AD by some of the lifestyles. And remember, the healthy lifestyles are also related to medical conditions as well. So one of the very important points is what we call the schooling, education. So we know that if we have more schooling years in a young age, it is actually protective. And the cognitive activity at the old age is also protective. So that's why you can see we in general encourage the elderly to participate in a lot of different kind of tasks that help to train like a judgment and like group games that interacting with others, that is actually beneficial. So these are associated factors, but we know that AD is actually a disease that has a strong genetic heritability. So from the twin studies, we know that the AD risk is actually 60 to 90%, 80% dependent on the heritable factors. So the heritable factors are genes. So we have a lot of the genome-wide association studies, what we call the GWAS. So identify a lot of genes that are at risk to develop AD, and some are protective against AD. So what these genes actually do is that they will affect a lot of the signaling pathways along the pathophysiology of AD. For example, the genes may modulate the amyloid deposition, will change the immune response, may affect the lipid, because lipid is one of the components in the brain, as well as some other factors that affect the brain. So among all these different, we call the causative genes, we see here we have three groups. So this is the one that is the strongest risk factors. That means you have a mutation here, it actually affects the major pathway which gives rise to the amyloid pathology. So these patients, if they carry these genes, they have early onset AD running in families. But we have a lot of the variants or alleles that are sporadic. So, and among these, all the alleles, I want you to be aware of these, ApoE4. I'm sure some of you may have heard of this before. So ApoE is apolipoprotein E. Lipoprotein is everywhere, basically. So in the brain. So if you carry the ApoE4 allele, if you carry one allele, the risk of developing late onset AD will be 3 to 4 times more than those who are not carrying this allele. We'll come to this allele later when we talk about our lab's finding. So genetic studies is actually a major focus in our field, because we know that from the genes, we'll know the downstream what will happen, the proteins, the lipids that are affected. So what do Alzheimer's disease presents? So remember the triad of the 3 major domains of the symptoms. So basically these symptoms arise when the amyloid pathology and the brain pathology affects different parts of the brain. So the most important, of course, is the episodic memory loss, which because the disease starts at the hippocampus area. So the problem is forgetting recent events, what we call the immediate recall. So it's very common to see the patients, they keep asking the same question because they cannot retain their short-term memory. They still remember the things what happened many years before, but it's very hard to remember what you just told them a few minutes ago. So that's why they will replace the things, they will miss their appointments. But there is another part which is very important, is the cognitive impairment. So what we call the higher brain functions are affected. So first, the visual spatial. So you will imagine when we are stay here, right? So you are looking at something. So you need to have an orientation of what happens around you. But if this has problem, that means they don't even know the directions, the orientation. So that's why it's very common to see AD patients getting lost. A lot of police will receive a lot of calls like, my family lost in the streets. They cannot find their way back home, and they cannot recognize the faces of their relatives. Language is also a very important part in AD, because they have some problems understanding the words, expressing themselves, and in some AD, some variants of AD presentation, they have major problem in the language. Executive functions are usually will have see this problem in the later stage of AD when the frontal lobes are affected. So they have problem organizing, they have problem in judgment and reasoning. And finally, the problem is calculations. So many of the patients with AD, they complain that they cannot even do some simple calculation. I once remember I saw a patient who was a retired engineer. So you can imagine highly educated, but when he developed AD, he couldn't even do some simple calculation. So it really will have a lot of impact on the self-esteem, their personal lives, daily activities. So this is a concept that's to remember. So finally, in the moderate to severe AD, when the frontal lobes are very severely affected, we do see a lot of neuropsychiatric disorders. So for example, mood disorder, depression, anxiety, and agitation, especially at night. So many patients, they may suddenly wake up at night, scream, shout, and very common, you will see the patient's relatives come and complain to you, crying, while the patients, they are completely unaware of the problem. So this is the problem that we usually see. So, and also delusions and hallucinations. So another common thing we observe is that they will tell you, I see my relatives who have already passed away, but they saw them in the room. So it's not ghost story. So this is actually delusions and hallucination. Changes in personality, loss of empathy, especially poor hygiene. So you can see there are so many symptoms, and these symptoms, some will come together, some will come separately. So when we manage the patient, we need to consider all this and what are the impact to the patients and the family. So how do we diagnose AD? Unfortunately, the definitive diagnosis must be made post-mortem. When the patient died, we got the brain and then we study the pathology. But that's too late because the patient has already died. So we want to diagnose early accurately. So a group of specialists, you can see here, the National Institute of Neurological, Communicative Disorder and Stroke and Alzheimer's Disease and Related Disorder Association, give a criteria. So this will help the doctors to diagnose the disease accurately and early. So first of all, we give a probable diagnosis based on, most importantly, the clinical presentation. So you must present the symptoms I just talked before. Then we'll assess the domains, your memory, your cognitive. For example, we have the mini mental states examination, the MOCA. So these are validated scoring systems. So we give an objective score to diagnose and to monitor. Most importantly, we exclude other causes of dementia because there are lots of dementia. There are causes that it will give you a dementia-like syndrome. For example, nutritional deficiency, like the vitamin B12 deficiency, some hypothyroidism, and actually depression itself will cause dementia symptoms, and also some of the brain problems as well. We exclude the causes, we treat them. And then also we find if there are other neurodegenerative diseases, because the management, the drug treatments are different. Then we have some support from the radiological evidence. We have our amyloid PET CT and also the MRI scans to identify the pathologies. We can't get the brain and get the brain out to stain, but we can use the scans to help us to assess the pathology and the brain volume loss. I will show you in the next slide. Another very important part, because of the advances of the technologies, we're able to identify some biomarkers in the cerebrospinal fluid in the brain and also the blood to reflect the pathologies in AD as well. So first of all, this is the two very common scans we do. This is what we call the amyloid PET scan. So this is the 11C Pittsburgh bound compound that is a radioactive tracer. So we inject this into the blood of the patient. So this 11C PIB will bind tightly to the amyloid plaques. And because it's a radioactive, so that's why you take a PET scan immediately. So you'll see the uptakes here if there is the radio tracer binding to the amyloid pathologies. So this is from the same patient of moderate disease. So you can see red is a lot of uptake here. Can you see? A lot of uptake and also a lot of uptake along the whole cortex. So that means these are the areas that you have the amyloid pathologies. And then we go to the MRI. So the MRI, what it tells is actually the brain volume. So there is brain volume loss in AD because the neuron dies. So you can see here, this is the section, the same coronal section. So you can see the brain is actually very shrinking. So you see very like shrink. The temporal lobes and also the overall the cortex are actually shrunk in volume. So that is how it helps us to diagnose AD. Then biomarkers. So you can see along the disease from normal to mild impairment to severe impairment, there is a lot of markers that reflect the AD pathologies. For example, the A-beta 32, this is the amyloid peptides. We have the p-tau, the phosphorylated tau. They can be detected in the CSF and the blood. And these reflect the disease. And we have some markers to reflect the neurodegeneration. For example, the NFL, the neurofilament light chain, which will help us to tell that what is the disease stage it is. So you can see, for example, A-beta 42 usually rise in the early disease, while the tau will be a bit later. And then when you have neuronal loss, then you have the NFL increase. So it helps us together with the imaging and the clinical symptoms to help us to diagnose AD and monitor the disease progression. So treatment. Unfortunately, we don't have a curative treatment for AD now. So mostly we treat by symptoms. So with symptomatic treatment is basically to use the drugs to modulate the neurotransmitters. For example, the cholinesterase inhibitor to promote the acetylcholine pathway, NMDA receptor antagonist to suppress the NMDA pathway. We should treat the neuropsychiatric symptoms with the atypical antipsychotics, antidepressants, and anticonvulsants. And now we have more drugs coming, and I'm sure you have heard of the disease-modifying treatments, including the passive immunotherapy, the aducanumab. It is a monoclonal antibody which target against the amyloid peptides. And there are some more coming in the clinical trials, maybe the vaccines or the aggregator that may come up in the market soon. In Hong Kong, we have all these treatments. So it's usually prescribed by the specialists that are trained to see the AD patients, including the neurologists, geriatricians, and psychiatrists. So it's all available in HA, which means in the public hospital. So this is actually also a very important slide because we need to treat with the medication, but at the same time, we need to support the patient and the family. Remember all the symptoms I told you, and we don't have a curative treatment. So that means the doctors are doing here to detect, to treat, but at the same time, we need a lot of other people to help. We need the physiotherapists, occupational therapists, and the psychologists to help with the physical activity, the dementia-related behaviors. As well, we need the social worker because many of the time, the caregivers may not be able to work anymore. So financial support, and we need the support from the society because we need facilities, we need daycare centers. There is a lot of things, especially the education, to tell everyone actually what is AD. You need to bring the patients to the clinic early if you think there may be some symptoms. So this is something that is very important. And if you do not educate the elderly are afraid, they will not go to see a doctor. And that is usually what we see in the Chinese population many years ago. So that is, in general, what we talk about the AD. So then in the next part, I will going to talk something which is related to us, the AD in Hong Kong. So there are two previous studies, one in 1998, one in 2008, which studied the AD population in Hong Kong. So from the 1980 study, so it was estimated that it affects around 7.2% of the local population. So you can see when you're older, then the chance of having AD is higher, that's for sure. And the AD prevalence increases with age, and it's increased with female. So the white is the female. You have more female having AD. So another study by Professor Lam, they look at the risk. And it also similar to what I presented to you. So the AD risk actually increases with age, with sex, the female, decrease with education, and increase with cardiovascular risk factors. So however, these studies are done quite some time ago. And we know that actually the Hong Kong population changes a lot in the past decade. So this is the population by group over the 10 years, based on the census, the results in 2021. You can see the age group, right? The group that is 65 plus, what we call the elderly population, is increasing steadily. Now it's 20%, which means that if you go to a street and you pick up someone randomly, 1/5 of the chance that is over 65 years old. So remember, I tell you, AD risk increases with age. We have an aging population. So that means we really need to know what Hong Kong is going on and how the patients are in AD, with AD are treated now to plan our future. So that's what we did. We have a collaborative study with the Data Collaboration Lab of the Hospital Authority. So they have a platform which is called a Big Data Analytics platform. So what they did is that they gather all the written and the electronic records under the HA. So that means all the public hospitals in Hong Kong. So for researchers, we apply and then we will have access to this data. So then we can look at the disease we are interested and all the related data, including the demographic, the clinical records, the diagnosis, the investigation, and the medication records. So we did a search between the January 2007 till December 2017 and to study the AD. This is a 10-year period. So the time when we started the study, the data is only till 2017. So that's why we did it till 2017. But now we know that they are adding more data. So it will be till 2019. We heard last year. So they are continuing to add up more data. So it actually helps us a lot because these are very valuable data that we know how Hong Kong population is doing. So what did we find out? So we find out that we identified 23,467 patients with AD during this 10 years. So it's based on the documented diagnosis. So among these patients, 70% are female, so a female predominance. And also the age, most of them are over 85 years old. It's actually quite old. Some of them is between 75 and 84, and a few around 10% is younger than 74. And we look at the mortality, the death rates. Over the 10 years, it's gradually increasing. And now it's reaching around 15%. So what causes death? The top, half of them died of pneumonia, that is infection of the lungs. So this is very common because especially in the later stage of disease, the patients may be very fragile, they may have limited mobility, and they have a higher chance of choking. So that's why the pneumonia is the commonest cause of death. Followed are the heart attack, heart diseases, cancers, and actually other types of infection are also common. So mostly probably related to a poor immune system and also a poor mobility. So that's the cause of death. So what about other diseases? So before that, let's have a look of our population and other people's population. So you can see we compare our cohort here with other cohorts, some other local studies before, and also some overseas studies. We do see a similar pattern of female predominance. That's for sure. We know that this is common. But for us, we do have more patients diagnosed at the later age. For example, 85, you can see the Taiwan cohort is much younger. US cohort is also younger. So why? What we think is that a lot of possibilities. So the first possible cause is that a lot of people may not be aware of the symptoms, and they are very afraid to see doctors, because there's one local study before that they they asked the elderly. So the dementia AD is actually the second most feared disease among the elderly. They're very afraid. They don't want to talk about it. And so that's why maybe when they present to the doctors, it's already too late. So that's why, because this is the age at diagnosis, it's not the age at onset. So that's why the age is very late. Another possibility is maybe related to the gene, because our group did study on the frequency of the ApoE4 allele, the allele I just mentioned. In Hong Kong, in Chinese population, the frequency of the ApoE4 allele is actually lower than the Caucasians. So maybe it's really true that our AD onset is much later compared to the Western population. But these are postulations that from the observation. So what about the patients? What do they have other than AD? So you can see they are elderly. So hypertension, diabetes, hyperlipidemia are common. So that's why the drugs treating the hypertension, diabetes are also very common. And because you have all these hypertension, diabetes, and hyperlipidemia, so they also have a high chance of having the cerebrovascular accident, stroke, heart attack. And around 10% of the patient, they also have some concomitant cancers, either before or after the AD diagnosis. So if you look here at the drugs, right, the first three is common because you have hypertension, diabetes. But if you look here, you can see the use of the psychiatric medication is also quite high. So half of the patients have taken the antipsychotics, and around 40% have taken antidepressants along the whole course of disease. So that's why we are quite interested in the medication pattern. So that's why we take a deeper look at the medication. So interestingly, if you look, we look at the record, only around 40% of the patient have taken the drugs for AD, that what like cholinesterase inhibitors or the NMDA antagonist. It seems the level is not that high, right? Okay, they have AD, but we are not treating them. Why? One of the possible reasons, it's very hard to tell exactly, but it may be because of the limitation of the drug in the early 20s, because these drugs are actually introduced to the market or introduced to Hong Kong in 2011. At that time, they are special drugs. Special drugs are not so easily available to all the patients. And then afterwards, after 2015, and then all these drugs become general drugs. So it may be related to the limited availability in the early times, because our cohort is from 2007 to 2017. So probably if we go to a few more years later, we'll see the drug usage is higher. So we take out this group of patients. We want to see if they are taking the AD drugs, and if they are not taking the AD drugs, is there any difference in the medication pattern? So we define the chronic and long-term AD medication users as they have taken the duration of drugs for more than a year. And you can see most of these patients, if they have taken the drug, they've taken them more than 1 year. Like even like 30% are taken more than 3 years. That means they're taking it regularly. So if we compare the medication long-term users with the non-users, you see they're in general younger, so more aggressively treated with the hypertensive drugs, diabetes drugs, and lipid regulating drugs. We do not exactly know why, because it's a more like observational study. But another important part is here. So you can see the amount of patients who need antipsychotics is much lower if they are taking the AD drugs regularly, while the antidepressant pattern is different. So that is very interesting, because why would this happening? Is it because of the control of the disease will also control the neuropsychiatric symptoms? So then we go on to look at this part again. If you look at the use, because it's very common that it won't be having one neuropsychiatric symptoms. You will have depression, and then you have sleep problems. So hypnotics is sleeping pills. So we see whether they need a lot of these medication for the psychiatric symptoms. And you can see around 6% of the patient, they have taken 3 of them at the same time. This is simultaneous. So this is actually not a small number. And when you look between the long-term users of AD drugs and the non-users, and you see the long-term AD users, actually, they do not really need the use of the antipsychotics and hypnotics. So we try to see what may be the reason for this practice. So there is a local study like looking at the AD patients' admissions, and they find out if they use these drugs for the neuropsychiatric symptoms, it's actually they have a lower chance of going to the A&E, probably related to the emergency services and the hospitalization. And we know that from another study that the psychosis, the behavioral problems, and the mood problems are actually strongly associated with carer stress. That is understandable. So it may be a practice that we really need to control the neuropsychiatric symptoms to actually not only to ease the symptoms, but also to help with the carers as well. So this is something we observed from the study. So from the study, actually, we are thinking again of actually the AD in Hong Kong. So probably we are actually doing quite well, because we diagnose the patients, we manage them, that is by the doctors. But at the same time, I think from the mortality data, from the drug use, we'll need also a lot of work on the health lifestyle. For example, the social engagement, the lifestyle exercise to improve the well-being of the elderly. So this is to reduce the complication and mortalities. At the same time, we need to think about our palliative care if at the late stage of disease, and also the public resources like the daycare centers and also the OH home, etc. at the late stage, and also the support to the family as well. So now what we are saying is will be a multi-dimensional geriatric care. It's not only to treat the symptoms, but treat the patient and the family as a whole. So then we will go to the next part, which will really go to the science level, or we go to the pathophysiological level. So actually what happened in the brain in AD, and I'm going to share with you our lab's findings of the IL-33 and ST2 ligand signaling, which is actually quite exciting. And we're very hopeful that it can give you some new ideas in this field and to give new therapies options. So first of all, we talk about AD, the symptoms, diagnosis. So actually what happened? So the hallmark of AD is actually two things. One, deposition of the beta amyloid, what we usually call A-beta peptides, and the neurofibrillary tangle, the NF tangle with pathological tau protein. So they are toxic. So because if they are present a lot, then it will kill the neurons surrounding and spread. And when the neurons are dead, then your brain shrink and your function impaired. So on the left hand side, it is immunohistochemical staining of brain from AD patients. So this is from frontal cortex. So you can see what happens in AD is that there is a problem with the cleavage of the amyloid precursor protein. Amyloid precursor protein is actually a protein, it's a component in the neurons. Usually it's cleaved normally, but if it cleaved abnormally, you will give the A-beta peptides, especially the A-beta 42. They are very insoluble and they tend to aggregate and then form the plaques. So these brown dots are actually all the aggregates of the toxic peptides. So you can see the whole brain is actually affected, the brain, the ribbon. So this is another staining which stains the phosphorylation of tau. So what happened here? So this is actually a neuron. So you can see the brown, these are the staining which stains the phosphorylated tau protein. So this is actually toxic as well. So these two components is the cause of the AD. And that is what we want to remove because they are toxic. So how to remove them? In the brain, we have our microglia. So microglia is the macrophage, resident macrophage in the brain, our immune cells. So we call them scavenger cells because they are responsible to take up these A-beta and also to clear them. So on the left-hand side, you can see this is another staining. So now we have two colors because we are doing a double staining to stain up the brown, which is the A-beta, and the purple red are actually the microglia. So you can see the microglia is trying to go to the plaque and is interacting with the plaque to try to clear it. So the microglia is not only responsible for the clearance, it's also responsible for the immune reactions. So it releases cytokines so to attract more microglia to come to work together and activate them. So from the right-hand side, this is an immunofluorescence staining. So we have a dye. This is a Phi S dye, which will bind to those hard cores of the plaque you can see here. And the A-beta are the insoluble A-beta around. So what here is that you can see the green microglia is trying to go in. You can see interacting with it and try to limit its spread. So you can see wrapping around. So this is what we find out that the microglia is doing to try to limit the disease spread. And we know that a lot of the AD risk genes in the GWAS are associated with the microglia action. For example, the ApoE allele I just talked about, TREM2, CD33, they're all working along the microglia pathways. So we believe that if we can modulate the microglia, we reverse the problem with the genes, or we promote along the activation, it should help in treating AD. So that is our focus of our lab. So we study a signaling pathway, which is called the alpha-3 ST2 ligand pathway. So IL-33, the interleukin 33, is a cytokine. So this is a cytokine released by the astrocytes, and it will be released when there is injury. So if there is brain injury, the astrocyte sense the injury, it will release the IL-33, and the IL-33 will bind to the ST2, which is receptors expressed on the microglia. This is a complex, what we call the ST2 ligand, and this IL-33 binding here, it will actually initiate a downstream signaling pathway to activate through the AP1 and the NF-kappa-B. So then the microglia will get activated. So from our study, we found out that if we stimulate the microglia with the IL-33, this microglia will become an IL-33 responsive microglia. So what it do is that it will have a transcription factor activated, and then there will be a transcription of the genes, which is related to the activation. So MHC2 is the major histocompatibility complex, which is very important in the immune function. And then these IL-33 responsive microglia will be activated. They will take up more A-beta. And then from a mice model here, if we give the mice IL-33, you can see the plaque, the brown of the plaque load will be much reduced. And these mice, when we do some behavioral tests, the cognitive dysfunction will be restored as well by the long-term potentiation, the LTP, as well as the behavior. So that means these signaling pathways actually helps to activate the microglia and clear the A-beta. So then we go to another marker that is of our interest, is the soluble ST2. So soluble ST2 is actually a decoy receptor of the interleukin 33. It competes with the IL-33 with the ST2 receptor. So it is a secretive isoform of ST2, the full-length one. And if it binds here, instead of the IL-33, it inhibits this signaling. So this signaling will not go on. Normal situation, this soluble ST2 is a physiological marker for the negative feedback. So because you cannot have over activation of the microglia. However, we noticed that in a lot of diseases, this soluble ST2 level is higher, which means that the soluble ST2 may have a role in the disease, which inhibit the microglia function or immune cell function. So we are interested in that, and my colleagues, so we got the first study of a local cohort of 80 patients. So we are now talking about Chinese patients in Hong Kong, and they're recruited at the Prince of Wales Hospital. So we studied their blood samples and identify a biomarker, which is the soluble ST2 level in the plasma, is associated to the amyloid pathology in the brain, as well as the clinical outcome. So we believe that this is a potential pathway to modulate the microglia function. And the findings has recently been published in the Nature Aging. So I'm going to go through the most important findings in this paper and highly recommend you to have a look because it involves a lot of our work. And it's actually get a lot of comments, even in the world, in the Alzheimer's forum as well. So it's very positive results, comments as well. So first of all, most important, we got the blood from the patients in Hong Kong, and then we analyzed the blood for the soluble ST2. You see, in the 80 patients, the level is much higher. So it's increased. And if we correlate the ST2 level with the gray matter volume, the MRI, the volume of these patients, you can see if the level of ST2 are higher, the gray matter volume loss is also negatively correlated. So that's why you can see here, if the level changes, actually the gray matter volume change is there. So that's why we see the plasma probable ST2 level will actually associated with a clinical finding. Then we go to a group of European cohorts in UK. We obtained the postmortem brain tissues from the 80 patients, and then we study the CSF ST2 level and the plasma ST2 level. And then we see that you can see the plasma soluble ST2 level and the cerebral spinal fluid ST2 level actually correlates. So that means they are positively correlated. And if you look at the relationship between the CSF soluble ST2 and the amyloid plaque load, like the staining I showed you, if you have a higher soluble ST2 level in the CSF, you have a higher A beta load. That means the AD is more severe. So from these two, actually what tells is that the plasma soluble ST2 actually also correlate with CSF, and the CSF correlate with the A beta load. So the plasma level of the soluble ST2 can reflect what is happening inside the brain. So after that, we ask ourselves, so where are these soluble ST2 come from? So we find out that actually there is a gene which encodes the ST2 ligand. There is a gene locus, the gene locus here, which will affect, the mutation will affect the soluble ST2 secretion from the endothelial cells into the blood. If you got the mutation here, what we call the RS1921622, this mutation will have A allele. So you have this mutation on the A allele. And if you carry both A allele, the plasma ST2 level is much lower. So this is good because it's high, it's not good. So it's low, it's good. And then if you carry one allele, you will have also a big decrease compared to non-carriers. So this is what we call the homozygous carriers of the A allele. So it seems that this genetic mutation controls the secretion of the soluble ST2. So then what happens? What does this allele do? What is the risk with AD? So this is the Mendelian randomization analysis. So this time we have our own Chinese cohorts, the circle one, and the European cohorts from our collaborators. So we see that actually this A allele, we see the effects mainly in the female patients carrying the ApoE4 allele. This group of patients are actually at the highest risk of AD because they are female, and at the same time, they also carry the risk ApoE allele. And with this allele, the effect is mainly in this group. It means that this allele will be actually helping those patients which are of the highest risk. Then we go on to see how this allele is correlated with the clinical findings. So in the Chinese cohort, what we call the discovery cohorts, so we compare the clinical outcome of the patients who carry both alleles, one allele, and not carrying any A allele. You can see that this is called the dementia-free probability. So if you carry both A alleles, the chance of getting the AD delayed a bit. So the disease-free is a bit better. And if you look at the MMSE score, this is the cognitive score, those patients with both A allele has a higher score, that is better. The higher is the best, so the full mark is 30. While those are non-carriers, they have the lower score. And if you look at the gray matter volume, that you monitor the gray matter over time and see how they progress, because you don't want the volume to be lost, right? So if you see the red one, it's actually the ones having two A alleles. You can see that volume loss is basically very slow compared to those without any A allele. So it seems that from the clinical observation, the association study, the A allele is actually a protective genetic variant. And we validated our data with other overseas replication cohorts from UK, from Australia, from Japan. We see the results are reproducible. So how can it affect how the genetic variants affect and how the soluble ST2 level affects the pathology? So now we go back to our European cohorts where we got the patient's postmortem samples. We compare the amyloid pathology between those who carry no A allele and those carry at least one A allele. You can see from the pictures, so this is the most severe. Those with the ApoE4 risk, and then they don't have any protective A allele. Well, if you see, if there is one protective A allele, even if they are ApoE4 carriers, the plaque load is much reduced and the pattern is very different. So you can see here the plaque load of these patients will be comparable to those without ApoE4 allele. So this is good. It seems that this protective A allele is a bit rescuing the problem in these risk patients. So what did they do? So what do the allele do? So we found that when we take from the same cohort of patients, so these are the sections. So we get the frozen samples and go for the analysis at the molecular level. So these are the microglia. So you can see this is actually showing you that the microglia from the patients with A allele, they have a higher expression in the genes which are related to activation. For example, CD74, which is related to the MHC2, ApoE along the downstream pathways. And this shows that these microglia are activated at the molecular level. So we believe that it should be related to the microglia. So how to prove it? Then we need to get our help from our mice model. So we have a mice model. So because we know that soluble ST2, if it's higher, it's not good. If it's lower, it's good. So if we inject the soluble ST2 into the mice, we should expect a worsening of the disease. So what we did is that we inject the soluble ST2 into the ventricles. And then at the day 28, we observe the A beta deposition and the microglia from the mice. And then you can see the difference is very obvious. So this is the control with the control substance injected, and this is the soluble ST2 injection. You can see we'll have one-fold of the changes in the amyloid plaque load deposition. So you can see there are lots of amyloid plaques if we inject the soluble ST2 in the cortex as well as the hippocampus. And then we also go on to study the microglia as well. So you can see here, so the white is actually the amyloid plaque and the green are the microglia. So you can see if we inject the soluble ST2, so the microglia is far away from this plaque. It's not interacting at all. So we compare here. So here is a plane that we cut in this way. So you can see the green microglia is touching the white plaque, while here is actually very far away. So we compare how the microglia cover out the plaque, interact with the plaque. And then we can see that if we have a soluble ST2, that is much impaired. So it kind of proves that the soluble ST2 is really helping to reduce the amyloid pathologies through the microglia activation. So this is a summary of what we identified. In the case of AD, we have more soluble ST2 released from the endothelial cells into the brain, and these inhibit the IL-33 binding to the microglia and reduce the IL-33 signaling. So then the A-beta clearance is reduced and the A-beta deposition is increased, so we have the disease. So our findings of the soluble ST2 and the RS192-1622A allele actually will have a lot of directions in the management. So we can stratify the patients. So for example, those who have higher level and lower level, the A allele carrier and the non-carrier, the treatment options may be different. We can use the soluble ST2, which can be easily measured in the blood. So we take the blood and then we can monitor the disease progression. And actually, we are now doing a clinical trial to see if we can reduce the soluble ST2 level, that it may be helping with the AD. So our clinical trial is ongoing, and we are also looking further on how these actually affect the microglia pathways, the signaling pathway, how to clear more molecular mechanisms, phenotypes. And we are now working on these, and hopefully we can show more exciting data in the coming years. So that's all today. And let me introduce our lab. So this is our lab in UST. So you know Professor Eve. So I'm sure you know her. And then we have Professor Fu. She's mainly responsible for the science part. And we have Dr. Fanny Yip. She's working closely with our clinical collaborators around Hong Kong. So the paper is mainly on the Prince of Wales Hospital cohort, but actually we have cohorts in Queen Elizabeth Hospital, in Queen Mary Hospital, Heaven or Hope Hospital, and also we're expanding our cohorts to the United Christian Hospital this year. So we have all our lab members here. So Jason is mainly responsible for the paper I just presented to you. We have very good postdocs and PhD students working on the genetic analysis, as well as we have a lot of PhD students working on the mice model and the molecular pathways, and also the human sample analysis. So these are our collaborators around the world. So Professor John Hardy, I'm sure you know him. He's the one who first presented the amyloid cascade in UCL. We have a collaborator in Germany. So I'm sure you may heard of Professor Hendrik. He works a lot on the biomarkers. Tony and Colleen from US and Australia. And also we have a collaborator from mainland China and Professor Zhang from UST. So we also have our Chinese cohort. Besides from CU, we have from Shanghai and Zhejiang, and also our close collaborator in Australia. And also, of course, the UK Brain Bank, where we got most of our postmortem samples there. So we are part of a lot of the cohorts as well. So gene imaging as well. So it's actually all the collaborators together. So that's why we can provide so much findings in AD. And finally, we have all our support from the grants in Hong Kong, as well as the grants from China. So that is what support our research. So this is the UST campus in Clearwater Bay. So thank you very much. And hopefully I give you a talk that you know more about AD. And thank you. And I welcome any questions.
Probably for a better time control, we may postpone the Q&A a little bit later after two talks. Okay. Now let me pass the floor to Dr. Mason Fong.